Today, continual advances and innovations are present in all areas of life. This is particularly true in healthcare professions and is of great importance to us all. Many people suffering from serious diseases are restricted in their quality of life. Many of them require a simple and safe long-term intravenous access, especially in the treatment of cancer. This access is used mainly for chemotherapy, pain therapy, parenteral nutrition, blood sampling, and blood transfusions. The introduction of implantable subcutaneous port systems under a skin barrier as a long-term venous access has led to widespread employment of these devices. These have been useful in many therapeutical settings, particularly in cancer treatment, and are associated with very low complication and infection rates. Handling of such systems by the patients themselves have posed no major problems. The PakuGB company, specialized in the development and manufacturing of pure titanium port systems, offers a variety of different, hypoallergenic, highly biocompatible systems. Differences exist as to the dimensions and weights of ports and materials, as well as in the diameters of the catheters, either silicone or polyurethane. Other indications include arterial access for direct organ perfusion, as in the regional treatment of abdominal tumors or metastases. In these cases, the catheters are equipped with 3 additional fixation rings. Peridural pain therapy. Employment of double-lumen catheters as an alternative vascular access for hemodialysis in renal failure. And finally, peritoneal chemotherapy and peritoneal dialysis. Basic requirements of a port catheter system are biocompatibility of materials, lightweight, proper design and easy handling, stability of the silicone septum, secure port catheter connection sites, and pressure stability. The procedure itself does not require extraordinary operative skills, and it is generally possible under local anesthesia. With the exception of general sepsis, coagulation disorders, and extremely rare cases of hypersensitivity to one of the materials, there are no contraindications. A low complication rate requires precisional implantation technique, high-quality system components, and proper postoperative care. Recommended sites for catheter placement are the cephalic veins, subclavian veins, or internal jugular veins. After general draping of the surgical field, a 5 cm longitudinal subclavicular incision over the deltoidiopectoral sulcus is made under local anesthesia. The vein is exposed and ligated distally, and a transverse venotomy is then performed. A small vein retractor is most helpful for placement of catheters. The heparinized saline-filled catheter is passed via a small venotomy to the vena cava superior, about 10 to 14 centimeters. The position of the catheter tip is confirmed by means of image intensification, but can be determined easier by intraatrial EKG electrode tracing. The need for a postoperative X-ray within 6 hours represents a mandatory legal requirement to recognize incorrect catheter placement. The port chamber is filled, surplus catheter is trimmed off. The catheter should be clamped with an atraumatic clamp prior to trimming to prevent air embolism. The catheter is then connected to the port chamber by advancing the sleeve over the catheter, which is then screwed to the port under gentle traction. Be sure not to twist the catheter during this procedure. The simple but most effective twist screw clamp connection site is resistant to high pressures. The product was tested with pressures greater than 3 bar. The connection site is easily disconnected when necessary. Patency of the system is tested with 10 ml of 0.9% heparinized saline. The port is then filled. Only special non-coring port needles should be used for puncture to prevent punch defects of the membrane. A special feature of the catheter is the conical tip, which facilitates placement into the blood vessel. The additional lateral opening near the tip of the catheter is a further advantage, especially when drawing blood from the port system. The port capsule is then placed into a subcutaneous recess away from the skin incision and secured to surrounding tissues with fixation sutures. Closure of the wound with subcutaneous and skin sutures. The port may be used the following day. For implantation of the port and catheter, different techniques, including Seldingers, are available with special introducer sets. The choice depends on the surgeon's preference and skill. Before every puncture, the correct position of the port chamber is palpated, and signs of infection or other complications must be excluded. The patient is in a supine position to avoid air embolism. The port is palpated, the skin disinfected, and the needle is carefully advanced perpendicular to the base of the port. The use of adequate port needles to avoid punch defects is essential in avoiding complications and increasing duration of implantations. Several so-called specialized needles with Huber bevel variations, presently available on the market, do not fulfill these requirements. They can cause punch defects resulting in liberation of silicone particles as well as needle bending. This is a demonstration of how a port needle can punch out tiny silicone particles which can enter the bloodstream. They may also cause occlusion or leakage of the port system as well as other complications. These microparticles are generally not visible to the naked eye and are sometimes lodged in the lumen of the needle. Recognition of this is often missed and the consequences underestimated, which may lead to complications. In contrast, the tip of the SFN port needle with its unique bevel and lateral opening cannot bend because the tip is not hollow. These needles are available in various dimensions and diameters to meet all needs. The choice depends on patient anatomy and the type of infused fluid. There is no danger of bending in this type of needle due to the special bevel at the tip. Always use a 10 ml syringe to avoid high pressure during injections. To avoid interactions with various drugs, cytostatic agents in particular, the system should be flushed with 0.9% saline. The system must be filled with heparinized saline after each use and after longer periods of non-use. 1,000 international units of heparin in 10 ml of 0.9% saline is recommended. In the literature, however, evidence of the advantages of heparinization has not been conclusive. Of paramount importance is thorough flushing of the system with saline to eliminate stagnant substances. Remove the needle only when the check valve is closed to prevent blood flow into the system or motion of the membrane. For drawing blood, a 20-gauge needle should be used. Meticulous hygiene and sterile handling technique are mandatory for safe usage of port systems and to avoid complications such as infections or thrombosis. Residual blood in the port chamber generally indicates faulty handling, leakage of the system, or unstable motion of the septum. In addition to the use of safe non-coring needles, well-trained personnel and sufficient information for all users are important. The Titan port is a beneficial long-term venous access with definite advantages for the improvement of life quality for patients receiving long-term care. Port systems can be left in place for many years. Generally, they are removed in local anesthesia at the end of treatment. Always in the right direction for the benefit of the patient, the PakuGB company is developing the proper port for every requirement, thus establishing strong connections to the vascular system for optimal treatment with Titan port catheter systems and SFN port needles.